till Wajid comes back. Oh, so it's happening now finally? Speaker is off. I'll tell you.
Hello, madam. Hello.
Hello.
Yeah.
Can you hear?
Yes, ma'am. Good morning.
Good morning. I just want to check whether it's echoing. I think these two together. Just give me 1 minute.
Yeah, okay.
Yeah, this. Yes, ma'am. I think I have to leave. Exactly. Yeah.
സംസാരിക്കുന്നുള്ള അൺമ്യൂട്ട് താമില്ലേ Gayathri.
Hello, sister, can you?
നമ്മൾ അൺമ്യൂട്ട് നമ്മൾ
I think leave computer audio picture. My God, this is good picture.
ഹലോ മാഡം ഹലോ
Last time, no, it was we don't have to. We have to use the speaker. ഹലോ
Just try it once.
Hello, can you hear? Can you hear us?
ഹലോ മാഡം
Can you hear me? Hello.
ഹലോ മാഡം yeah we can hear you.
Okay. Now, just give me 1
Your voice is not clear. Madam, can you hear us? Yeah, okay. Shall we start?
The presentation is on this. So who is screen sharing? Shuru? We'll start
Yes, yes.
presentation. Screen sharing should come on the top. No?
Yeah.
Images should come down.
I'm just confused today.
I'm going to do this next. So, very good morning to all of you.
Good morning.
Can we start?
Yes, yes, madam.
Okay, great. So, I hope that you can hear from there very clearly, because here it's much more easy for me to speak to all the
Okay.
participants, because we
Yeah.
are all here together. So, thank you. Sorry about that little delay in the beginning. There was some confusion about the technical support. So, today's discussion, which we are going to talk about, is ethics in palliative care. So, what do you mean by ethics? I know that all of you are very senior, very senior and trained, and doctors who are already leading many programs, and I'm sure you're seeing a lot of ethical issues in your patients and hospital. So when you talk about medical ethics, what's your idea of medical ethics? Best practice, very good. Best practice also comes from a lot of evidence, isn't it? The best practice, when you talk about best practice, it's a lot to do with our evidence-based practice. Yes, best. So but again, it comes back to the ethical part of it. What do you mean by ethical part of best practice?
A reasonable, acceptable mode of treatment.
A reasonable and acceptable mode of care or treatment. So, who decides what is reasonable or acceptable?
Team.
The team. Suppose I am working in this hospice. My team, the little team I have here, I will decide that this is how we are going to care in the hospice. Will that translate to best practice?
We should know the mind of the patient and the mind of the apprentice.
Okay, the one aspect you really want to bring is what is that patient wants. Patient and families' wishes should be taken into consideration. Very good. That is very important.
There are some rights of the patients.
Rights of the patient. So your judgment will be guided by the patient's rights. Okay.
The principles set by.
Sorry?
Principles set by.
It's principles set by some bodies, not WHO alone. So I cannot decide whether I'm going to give care to the patients in the hospice is best just based on my own decision. It's not my own decision. So there are certain other aspects also which comes into play when you say this is the most reasonable and suffer and I'll kill all those patients. Let's try to make them suffer. I'll kill all those patients. So is that ethically right? No. So many of you strongly saying no. Why? On what basis have you decided that? Why? I believe that a patient should be killed because they are suffering. But you're saying no. On what basis are you saying no? Majority. So how is that guided? What is right or what is wrong? How do you guide? On what basis you guide? One is you rightly said, some bodies, some health-related decision-making bodies, they set some guidelines. So based on those guidelines, we make some decisions. Anything else guides you to make, say, belief system? Very good. Our conscience, our belief system, our faith, yeah, religion. So, and our moral values, how we are brought up, and our moral values, and also sometimes culture. There's a lot of variation in what one culture believes from another culture. So a lot of these issues which we face are very culture in our context. For example, now it's very common in our culture for the family to be the decision-making person. Usually the family is involved in making decisions. The patient is, they give this implicit empowerment to the family to take a decision on their behalf most of the time, isn't it? So they say that my family will decide. And also very often when we discuss diagnosis or prognosis, we are discussing with the family, we're not discussing with the patient. And the family says, don't tell the patient. Is that right? Debatable. Because in our culture, we cannot see patient and the family separate. They function as a unit. Whereas in the West, it's very autonomy-driven decision-making. The patient says, I should know what's happening to me. I'll make decisions. So, whereas in our Asian culture, the family and the patients, they function as a unit. And it's very difficult sometimes to see them separate and make decisions. So all this, so a lot to do with culture, our religion, belief system, moral values. So all things make us to decide what is right or what is wrong, isn't it? So this is what we're going to discuss here in ethics today. When you define ethics, it's connected with beliefs and principles about what is right and what is wrong. And how medical ethics, how you decide what is right or what is wrong is governed by many things, because our human social behavior is governed by our customs, etiquette, ethics, law, morality, religion. Law also play a very important role, because if it is not legal, you cannot make these things, like I said, I want to kill this patient because he's suffering so much. I cannot do that, because law also say very strongly saying, no, this is not legal. I cannot do that. So law also is another aspect which governs what is right or what is wrong. When you come, one is ethics. And specifically when you talk about medical ethics or bioethics, we say it's known as medical ethics. It's a study and employment of moral values in medical science, specifically related to medical science. And it comes both in clinical care and clinical research. I'll share the slides with you. So even if you don't take it down, it's fine. You can take it. So how many of you are involved in clinical research? Any kind of research work? Have you ever done in your medical practice any kind of research? No. So, but I'm sure you're aware that when you do some medical consenting to getting involved in medical research, isn't it? So that itself is a one big area when we talk about. And in clinical care, things like informed consent. Yes. Are you familiar with all that? Yes. All of you, every day you're doing a lot of procedure. So this discussion about informed consent, that itself is a one big area of medical ethics. Like how much to inform? What do you mean by informed consent? Suppose I'm doing one DNC. So we know that DNC sometimes can lead to many complications. But when you're taking consent from the patient, to what extent are we going to give information to the patient? So there's a lot of debate going on around that, isn't it? Like, to what extent? Are we going to scare the patient by telling all possible complications, or are we just telling them the routine part of DNC, or going beyond that? So again, there's a lot of discussion around that. The scope of medical ethics, where all we face dilemma where medical ethical discussion happens. Promotion of ethical practice. Our practice should be very ethical. That's what we believe, isn't it? We should do a very ethical practice. And ethical breaches. When we breach ethical, just like practical practice, breaching the ethical practice. Ethical dilemma. This is one area where we're going to see a lot in end-of-life care situation. Just now you were discussing about one HIV/AIDS patient recently diagnosed, how one family member is taking decisions to go everything possible, another family member saying, no, just leave him alone. So this is an ethical dilemma we are facing here, what to do for such patients. So, and we are going to see a lot more in end-of-life care situation. I'm going to give you examples of those later. And ethical conflict. You must have seen a situation when patient is put on ventilator, for example. Yes. Whether could you continue the treatment? Shall we stop? Shall we withdraw the patient from ventilator support? There's a conflict. We don't know what is right or wrong, and often that leads to a lot of debate and questions asked. So these are scope of medical ethics. I'm going to discuss one patient here, and this is a scenario which we see very often in our practice. That here is a case study about a 21-year-old young man with relapse AML. AML means acute myeloid leukemia. And he complains of bleeding from the nose, gums, and petechiae all over the body. He received platelets and back cell transfusion a week ago. Only a week ago, he received platelet and whole blood back cell transfusion. But again, now he's bleeding. And relatives say, please give some more blood transfusion. Now he is a relapsed AML, bleeding. Just a week ago, he received transfusion. Will you go for more transfusion or not?
When the relatives insist and if they bring the blood, if they are ready to bring blood from blood bank, I will give.
Okay, so when you're saying relatives are insisting and they bring blood and say, please give, you will give. Okay. Do you want to challenge her decision in any way?
I would explain to the relatives about the prognosis and the possible outcome, and allow to make a decision based on that.
What explanation are you going to give to the relatives?
I do not, right now I do not know much about AML.
No, it is a relapsed AML, and his bone marrow is completely failed.
Yes.
And obviously, when you're giving blood transfusion, it's not, it's again and again you're required to give blood transfusion because bone marrow is hardly functioning. It's just living on that period of blood transfusion which you're giving. So that is about the medical.
So this case of poor prognosis.
Very poor prognosis. What will you explain to the relative? The same thing, as I told you, the same thing you'll explain to the relatives. Very good. Yes.
So, explanation, maybe the counseling part to say, even if you give blood, the outcome would be the same. You may be able to prolong or a little because the whole explanation has to and being it given, we are hoping it gets cool. I would say you may wherever you put this, you will take out from. So what do you want?
So very important.
Time may immediately may not be maybe 1 or 2 days, but from my side, I would suggest. I sometimes in my practice also I would say, if it is my relative, what I will do, that I can do.
Absolutely. So
And
that's
if it is my brother who is suffering from 21 years old, and this is said, maybe it is painful, yet I will take a decision not to. I say that goodbye. So why not?
very good. So one part of it is very often a lot of our treatment is driven by demand from the relatives that give IV fluids. He's not eating anything. Why don't you give IV fluids? Or give blood transfusion. I can't see my young boy suffering like this. He's again bleeding. So last time when we gave blood, so it didn't help him a lot. So let's give some more blood. So, or give oxygen. We know that both lungs are badly damaged. He's coming in severe dyspnea. Well, sometimes we see with advanced AIDS, both the lungs are gone, completely gone, full of infections, and there's no scope for any improvement. But there's need to insist on giving oxygen therapy. But all this comes with also a lot of problems when you give these kind of therapies. So very often we are driven by this pressure from the relatives and your own colleagues saying that you have to do something, and you give treatment based on that decision. But often this can be challenged, and because we know that it's how clinically relevant these interventions are. That's something you have to ask yourself. And many times one way to work around that problem is having a kind of open and very honest discussion with the family. What's happening and what is the goal of care? What is that we're going to achieve? Now, coming back to this patient once again, Madam feels that relatives are coming with the blood and we have to give blood transfusion. But medically, I explained to you it's a relapse AML and its bone marrow is failing. Okay, now he received platelet and Paxil just a week ago. Suppose you give now, how many days do you think you'll get the benefit? Not more than a week. So medically, do you think this is helpful for this child? Very maybe, and as bone marrow completely fails, this week becomes days and few days. Sometimes 2 days they'll come back with bleeding. So when do we stop? Do we need to stop? That's a question we have to ask ourselves. Because if we are not convinced, we cannot tell the relatives. So as a medical team, it is often very difficult when you're working in a team, you have your nurses, you have doctors, other doctors, and you may take a decision and the other doctor or nurse may not agree to the same. So it's very important that within the team, you have a consensus about when to stop. Do we need to stop? And when to stop? And those decisions are often not very easy. Let's accept that. This kind of medical dilemma, often it's not very easy. But we have to sometimes take a decision. And how do we take that decision? So that's something we need to talk about. So there are some principles which we follow based on which we make these decisions. Yeah. So one such principle is patient's autonomy. Did you ever ask this 21-year-old boy what he's thinking about all this? He's been coming to this hospital for last 3 years, underwent so much of chemotherapy, radiation, probably, and also now repeated blood transfusion, repeated antibiotics, repeated blood tests. So many times, every time you have to do a blood test, isn't it? We can't give blood transfusion just like that. And which means repeated hospitalization. So many times he is coming back to the hospital. So what exactly he wants? Have you checked with him? You expressed in the beginning about autonomy, my wish, it's my body, I want how to go about it. The patient's autonomy is something very important component which will be required when you're making a decision. Yes, yeah.
In our setup when we work, the people are socio-economically and educationally, and they believe in a lot of it is a given here also. Some of them might have not been married. insist, please do not tell. Then the problem becomes much more complex. And when we suppose we say, we have to tell, and within a week or so, if he dies after we say, the whole accusation will be to us to say that if he was not free, he would have survived. That he gave him a shock, and the shock is death. So how do you?
So absolutely. So here we are talking about one more angle to this difficult situation, or we call it as collusion. I don't know whether you had this discussion on collusion. Collusion is when you're shielding information from one party and you collude. So very often we collude, the medical team collude with the family, not giving information to the patient. This is a normal scenario, isn't it? The another scenario is like, HIV/AIDS patients. The patient will say, don't tell my wife. So you're colluding with the patient, shielding the information from the family. Or sometimes the family does not tell you at all anything about their medical information. I've seen many patients we treat for cancer, they never tell that they're HIV positive. Accidentally, we find out later point of time, this patient is HIV positive. So this is what we call it as collusion. So dealing with collusion is another issue altogether, which may or may not be possible in today's discussion. But if there is collusion, we cannot exercise patient autonomy. That is very clear. When I say patient autonomy, patient's involvement in patient discussion. But if he doesn't know the diagnosis, if he doesn't understand the prognosis, he cannot exercise this choice. So yes, very important for us to understand that if there is a collusion, this may be interfered. This may not be applicable then. Yeah, we'll come back to collusion maybe hopefully if we get time. But that is one important issue which we face.
We have one question. When this admission diagnosis, informed consent we are talking about, in that case, now informed consent form, can we have a written to say that this was the patient will be part of the
So ideally, if you read the informed consent, the consent, if the patient has the mental capacity to take decision, the informed consent should be by the patient, not by the relatives. Yeah. That is the problem. And that's the reason we land up in medical legal issues, because very often we don't take informed consent from the patient, we take from some family members, and then we land up in trouble. The informed consent is valid if the patient is in that have mental capacity, if the patient gives the consent. And this whole confusion about not telling the patient we do something and then we land up in trouble. It's a very technical, very difficult issue actually, which we face. Yes, you're right. So when you come to medical ethics and we talk about decision making, one important part is the patient should be involved in decision making. But having said that, if there is a collusion, he cannot exercise that decision. That's something we have to understand. So autonomy comes from this Greek word called self-rule. Self-rule. What does the patient want? What is that he wants for his body? Let me make my own decision. Suppose we have some cough which is going on for last few weeks, and we go to a hospital and they do some investigation. Do you want to know why you're having this cough for last 3-4 weeks?
Yes.
Yeah? How many of you want to know that why this cough is going on in my body? May not be all, but most of us. When you're very sure about yourself that it's my body, I should know what's happening to me. Why is it any different when it comes to patients? Do you give them the choice? Yeah? So that's something we have to remind ourselves, that patients should be given the choice. But how do you practice autonomy? Respect for autonomy requires the doctor to provide full information in language and wording that promote patient understanding. A patient cannot exercise autonomy if he doesn't understand the language. Or when there's a collusion, same thing. So autonomy can be exercised only if there's the information is given and they have the capacity to make the decision. Both are important. The patient is confused, delirious. He cannot make an informed choice. So you have the capacity, you have to have the information to make this autonomy as a practical. The second principle which we talk about, which helps us to make a decision when we are in ethical dilemma, is do good. Is my blood transfusion is going to help this child? ask this question yourself. Is this blood transfusion going to make any difference to his bone marrow, his disease process, or even his quality of life? Are you giving any good to the patient by giving blood transfusion? So here I see a lot of strong no, isn't it? So that's another way to look at it, like when you're making decisions, whether it's right or not. So something called futile care. What do you mean by futile care? So don't think that all your treatment, when you say treatment, it's useful. A lot of what we give is often not useful. Then it ceases to exist as treatment. Advanced cancer, whose dyspneic, both lungs damaged, when you give oxygen, do you think it's useful? It's not useful. Then that ceases to be a treatment. It's not a treatment. Treatment is something which gives some benefit, isn't it? And that is known as futile care. Advanced lung cancer patient putting on ventilatory support. Again, there's no chance that he'll come around, no revival. So putting the patient on ventilatory support is a futile treatment. Giving IV fluids in advanced cancer patient or advanced HIV/AIDS patient, it's absolutely futile treatment actually. It doesn't give any benefit. Rather, it gives more harm to the patient. In what way can it harm? IV fluids in very advanced end-stage disease patient. Fluid overload, yeah, and pulmonary edema, yeah, dyspnea, more dyspnea. So it's no way it's helpful. Rather, it can produce more harm. So futile treatment, see, remember, for any treatment which you give, the goal of medical care is to achieve benefit above certain minimum threshold. Some benefit they should get when you give a medical treatment. Otherwise, it's not a treatment. And futile care fails to achieve that benefit. That minimal benefit we should achieve by your intervention. If you fail to achieve that, then it is a futile care. So when you say do good to the patient, we have to ask this question: is my intervention doing any good to the patient? Or is it a futile care? Any thoughts? Now, benefit, it's very subjective. When I say, is it giving any benefit to the patient? It's a very subjective thing. Who decides what is beneficial? Doctor, yes.
And the patient.
But patient also. Patient should also pursue. When I put the patient on oxygen, he's extremely dyspneic, advanced disease, whatever the cause, chronic heart disease, chronic lung disease, AIDS patient, or cancer patient. His lung is badly damaged, and you put the patient on oxygen, he's struggling, and he's trying to remove it, and you're trying to smother him with the oxygen. Yeah? If you ask the patient, what will be his response? Is it helping you? They'll say no. So benefit is very subjective, and often physician definition of benefit may be different from that patient. Advanced disease, who's dying almost, and he's dyspneic, and you put on oxygen, physician may be chasing the pulse oximeter, but patient says, I get no benefit. Your pulse oximeter may be 95, you're very happy. The patient is not feeling benefited. Then what decision will you take? Sorry? Exactly. At some point of time, you have to give up on because it should not be driven by your investigation or your machines. It should be driven by patient's outcome, what patient feels. Because very often in end-of-life care situation, what is your goal of care? Let's ask this basic question. End-of-life care, a patient who's gasping, you said you saw a patient who's gasping there. What is your goal of care for that patient? Comfort. When you are very clear, for this patient, my goal of care is comfort. Everything what you do, you should ask this question. Is this intervention going to make him comfortable or not? Your pulse oximeter is going to make him comfortable? No. You have to see what is that can make him comfortable, and that should be guiding principle for you. Sorry? Yeah, that should be the guiding principle. So define goal of care, and that will help you to make a decision. So benefit, as I said, it can be very different from patient perspective. When you're not very sure, go by patient's definition of benefit.
But giving this patient a little oxygen is going to benefit him Give him comfort also. Suppose his lungs are collapsed. He is short of breath. He is trying to breathe. Probably if we give him a little oxygen, it may give him a moment
Exactly.
for some time.
So when you give oxygen, if it comforts him, please underline that. So you have to ask the patient. You are not very sure whether oxygen is going to benefit. That benefit, it's not your pulse oximeter. The benefit is by the patient. So you have to ask him, when I put this oxygen, do you feel okay? Do you feel good? And you'll be surprised at how very often any end stage disease, they say, please remove this, leave me alone.
Most of the time they are not in a position to respond at that.
So, yeah. So all the more are you going to give oxygen to that patient when his patient is unconscious and it's not going to benefit? There's another question altogether. But even a conscious patient, I will still ask that question. The end stage is not, I mean to say 1 hour before that. I mean to say a few days before that, a few months before that, when you know that this is an irreversible state. You have to ask this question. So I think the whole thing will be helped if you ask this question about what is my goal of care. The goal of care may change from depending upon the stage of the disease. In early stage, your goal of care will be very different from a very advanced stage when there's a relapse and recurrence of disease. The goal of care changes completely. So you have to ask this depending upon the stage of the disease. Yeah. So once you reach a stage where it's recurrence, advanced disease, and goal of care is only about comfort, the whole thing will be applied. It will be very different then. First principle, we spoke about autonomy. Second principle, we spoke about doing good to the patient. Third principle is do no harm. So my question is, giving blood transfusion to this boy, can you harm this boy in what way?
It's a trauma and IV infusion.
So blood transfusion you can't give just like that, subcutaneously or orally. It has to be IV. And IV means you have to have a good vein. Do you think a patient who's gone leukemia treatment for 3 years almost, it's easy to find a vein? No. You have to admit the patient. You have to put a proper big vein or central line, which itself is a procedure. An end-of-life care patient, when you're subjecting such big procedure to a patient, hospitalization, he's away from home, and it's painful, isn't it? So when you're asking about goal of care, everything is going against that. Where do you think the patient would like to be in his last days of life? And here you're admitting this patient in hospital just because you want to give blood transfusion. He may die in the hospital in the process. He'll never be in the home. And usually when we say home, what is the one important reason they want to be in the home? Exactly. All end of life, if you give the choice, ask yourself this question. I'm sure majority would say that we want to die in the home, surrounded by loved ones. Whoever you are, your loved ones are, isn't it? And when patients, just because we want to give this blood transfusion, we admit them in the hospital because we have to get that vein, and he'll die in the hospital, away from home, away from his relatives, most of the time. Because in the hospitals, we don't let relatives, too many relatives be around. Maybe one maximum person will be there. If ICU means no relative, he'll die all alone, without even saying goodbye. Is that a good death? Is that what your goal of care you want to achieve? No. So you're producing more harm. So any other harm by blood transfusion? Reactions, and that can itself produce more morbidity to the patients. Any other problem? Infections, you are giving more infection to the patient. DIC, if it is where the product is very old or a repeated blood transfusion, DIC. Electrolyte imbalance, maybe, yeah. Sorry? Fluid overload, that itself can produce more distress to the patient. So you're failing everywhere in terms of comfort care. When you're saying the goal of care is comfort care, maybe you are not giving that. Just by that single intervention by you, you're producing more harm to the patient, isn't it? Yeah?
For the poor families and all financial.
Exactly, we're coming to that. Do you think giving blood transfusion is free?
No, it's very costly.
Most hospitals, it's not free. Yeah, it costs money. It costs money for the patient to be transferred from that remote village to that hospital. transfer and the discomfort and the problems which comes with that transfer of that patient. He's dyspneic and he's bleeding, and then he's going in this vehicle, difficult terrain, difficult place to reach that hospital for that futile blood transfusion, isn't it?
They do not understand.
No, we'll come to that. We'll come to that. Yeah, these are all our assumptions. Again, let's come to. We'll come back to that. And then you come to the hospital. The travel. Sometimes they don't even have a vehicle in the villages. They may have to carry the patient, and they carry river, go by boat, and then they come to the one place where they get a bus. And by bus they'll come to this hospital. So much of money spent, and so much of loss of livelihood because that family is coming with that patient. Because one person cannot hold that. One old frail wife, do you think she can hold that patient? No. So the whole family will be coming. Then you come to the hospital, and then hospitalization, nurses' charges, the blood product charges, and the everything, the hospital stay, everything costs money. To do this simple blood transfusion, when they come from the home, maybe they'll sell that one single plot of land they may be having. And in the process, what happens? The whole family comes to the street. The future children drop out. First thing happens, children drop out from the school. The whole future generation is lost. We are not realizing the financial catastrophe which we create by the simple gesture of giving blood transfusion. I'm sure you face this every day in your practice. You are working in the community, and you're working most remote places with most limited resources. You know how the family is devastated by these kind of measures, and for something which is not useful, end of the day, which is so sad. So when you make decisions, do patient's autonomy, do good, do no harm. And as you mentioned, blood transfusion, any side effects. And harm, it's total harm. I don't know whether you understand the concept of holistic care. We talk about physical, emotional, social, and financial. We talk about financial and spiritual also somewhere. The harm can be all the dimensions. The patient saying that why, what's the point of living a life like this? I'm troubling my family so much. Every time my family is troubled because of me. And the social reasons, emotional reasons, physical reasons. It's a total harm. We call it total pain, total suffering because of this simple intervention like blood transfusion. It's just a one blood transfusion, bigger impact. Then comes the one important part, another last part of your a component of medical ethics is justice. Balancing the need of the individual with that of the society. Is it justified to give blood transfusion to this boy who's having relapsed AML at the cost of selling that piece of land or house and his 2 children dropping out from the school? Or 2 children starving because of no food left at home? Is it justified? Is it justified you have this very precious blood group in your hospital and you have a boy who has just come with head injury? He needs that blood and you don't give that blood to that boy and you give blood to this boy. So we don't know. It's very difficult decision making, but somewhere you have to make this decision and you face this dilemma every time, isn't it? Whether to give blood, that limited blood you have, or one ventilator you have. Do you want to put a ventilator on a young boy who's met with an accident or an old man with relapsed disease and he's come to your hospital? Where do you put this ventilator on? Young boy. But some people may question. But you have to take a decision. So when you talk about justice, many things comes in justice. And one important part of justice is resources. Where do you want to put your resources on? It can be family resources. It can be hospital resources. It can be nation resources, because everything which comes in government hospital is free, but it comes from taxpayers' money. So are we right in wasting that taxpayers' money on giving unnecessary IV fluids, unnecessary oxygen? And it's not useful. Have you seen patients, dying patients, for hours together you put on the oxygen and it just flows, and you think you're doing something, but which is not helpful. And the oxygen flows. Oxygen costs money.
Yes.
Yeah. So, but we don't realize that it flows. And you waste so much of resources. So justice is an important part of medical ethics. So is this a fair allocation of the hospital resources, family resources, society or nation's resources? All the components come there. So coming back to this boy, so what is right or what is wrong? All the four components you have to balance. As I said in the beginning, often we are going to face this dilemma again and again. There's no right or wrong, but sometimes we have to make a decision, and your decision will be right if you balance all those four components. What does the patient want? Is the benefit perceivable to the patient? Will it do more harm to the patient? Is it fair allocation of resources? This patient, over a period of time, started bleeding in the lungs. It can bleed anywhere, isn't it? Leukemia, they bleed everywhere. He started bleeding in the lungs. He was extremely breathless. And I think you've seen in the hospice how many times for dyspnea, advanced dyspnea, we use morphine and benzodiazepines for advanced dyspnea, because morphine is very useful for advanced dyspnea in many ways. I hope you got a session on dyspnea and morphine. So morphine is very useful for this kind of dyspnea. So when this patient was dyspneic, so he was put on morphine and midazolam for breathlessness. Do you think this can hasten his death? In what way? So it can reduce the respiratory drive, and maybe probably there's a chance that his life is shortened because of this intervention. Now they were discussing about one child, methadone, a child who, Sanjay, there's one boy here, the huge mass, and he's drowsy, but he's having pain. So I said, let's speak to the family and have a consensus whether you want drowsiness but less pain, or more pain but less drowsiness. The choice, isn't it? A very difficult choice. But often when we make these decisions with the family, you'll be relieved that you'll be surprised at how family will help you to make a decision. And here the family said, please, I don't want to see my child suffering. Even if you increase the dose, I'm fine with that. So you're going to, after this, maybe you can go and discuss with Dr. Mustafa as to what they're planning to do with that child. And many times when we put them on parenteral, this kind of sedation, we call it palliative sedation, where we kind of sedate the patient to relieve the suffering. Yeah. So often when they face this ethical dilemma, this is called double effect. Weigh the potential benefit versus the possible risk or burden associated with intervention. Here you have benefit, but also there's a risk involved. This double effect extends even in normal practice, isn't it? Suppose I'm giving chemotherapy. What is one important complication of chemotherapy? Yeah, but and what happens to the blood count? Yeah, and we have seen in the ward many children sometimes when there's so much of bone marrow suppression, they die because of that. They don't die because of cancer. There always that burden is there or the risk is there. Yeah, but we still go ahead with chemotherapy because we think benefit will be more than the risk. The same thing applies here. We have to balance. When you talk about giving morphine and midazolam, understanding that it may reduce the respiratory drive, we understand that, but sometimes the benefit is much more than that. Even if it shortens a few hours, maybe a few hours it may shorten, but the benefit which you are getting in terms of reduced suffering may be much more than the harm. And it is ethically acceptable. I know these are all very thoughts which is very different from normally what we think, but this is what we are going to face in end-of-life care situation, and you can question this, but legally and ethically, this is something which we all accept. Just like chemotherapy can produce neutropenia and patient dying, but we still give chemotherapy. We don't stop giving chemotherapy. Same thing applies here. So people may ask, is it euthanasia then? What is euthanasia? Expand more on that.
With the definite intention that you are going to shorten the lifespan of.
Shorten the life?
No, end the life.
Here, The intention is, what intention? To end the life. Yeah, with the definite intention to end the life. Why?
Not suffer anymore.
So when the suffering is intractable and when the patient asks for it. The patient is not asking and you end the life, what is that? Murder. So you have to, it's a fine difference between that. Patient asking for it because the suffering is intractable and there's an intentional, deliberate ending of life by the physician. That is euthanasia. So here, if I'm giving sedation to this boy, morphine and midazolam, and his life may be shortened a little, is that euthanasia? What is your intention there? Intention is to comfort or reduce suffering. In the court of law, they always look at your intention of treatment. So very important that whenever you make any decision about treatment, A, involving the family, you're concerned about family not agreeing. You'll be surprised that if you create this opportunity for discussion, it should not be then when the patient is coming last moment coming in a vehicle, he's dying and he's almost about to die, you discuss all this. These discussions should start very early on. What percentage of people die immediately, sudden death, and what percentage of people, they don't die suddenly? Sudden death, where do you see sudden death? Accidents or myocardial infarction is examples. What percentage of people die like that? They say around 10%. 90% of patients, they live with some chronic disease or multiple comorbidity. Gradually there's a decline and they die. Don't you think you have enough time to discuss all this and prepare the patient and the family? We never do that. And towards the end of life, when these patients declining and dying, when suddenly dying, you start flurry of activity and you always land up in trouble because the family's expectations are not meeting with your reality. So the more and more people are talking about what we call something advanced directive. Advanced directives means beforehand itself start this discussion about suppose things go wrong and your disease progresses, how do you want your end to be? Have you thought about it? I know it may sound very difficult, but this is something which is very acceptable. In the West, it's very normal for all patients, they have discussed advanced directive. Recently, Government of India, they legalized this concept of advanced directive. It's quite legal in India to talk about these things and make a decision much before. Then doing it when the patient is no more in a mental capacity to take decisions. You know that Aruna Shaba case? The Bombay nurse who was raped and she was on that artificial thing. No one could take a decision about withdrawing that artificial feeding because there's no advance directive there. So people say don't talk about advance directive when someone is sick. We can make an advance directive. When we are healthy, we can say that if I fall sick or if I suddenly meet with an accident and I'm in a vegetable state, please don't put me on unnecessary treatment. I can make that choice. And it will be valid in the court of law. So, responding to your question, as a medical professional, we should also change the practice about how you prepare these patients and their family towards end of life. And most of the time, it is not a surprise. When they're dying, we know that they're declining, they're nearing towards end of life. Can we start preparing patient and the family? All the patients in the hospice, we do this dialogue, we do this discussion. Where if you ask Swaroop, I'm sure all these patients, they have a death plan. Very clearly we discuss about all this. So that when something goes wrong, it's not that they IV fluid dalo, oxygen dalo, this pressure never comes because they already they understand that. And all they usually, if you prepare them well, they say, please, I know that he's dying, but he should be comfortable. If you ask this one question, what is that you want for your loved one? Keep him comfortable. That's what they say. So coming back to euthanasia, is it euthanasia? So now we know the definition of euthanasia. Euthanasia is what? Euthanasia is not. Allowing nature to take its course. A natural death. We're just letting the death to happen, but we are keeping the patient comfortable. It's not euthanasia. You're not doing something. Kuch to karo. Because you're not doing anything doesn't mean you're doing euthanasia. Stopping biologically futile treatment. Suppose you put the patient on ventilator and you know that the ventilator is not helping, and when you pull the plug, that is not euthanasia, because what is your intent there? Remove the futile treatment and allowing the nature to take its course. That is not euthanasia. And this is also known as withdrawal of life support. Withholding life support, withdrawal of life support. Withholding life support, for example, not giving IV fluids or not putting the patient on ventilator, knowing that it's not going to be helpful. Or withdrawing of life support, taking out the ventilator. And this is in the recently government came out with the law. They're known as passive euthanasia. They say passive euthanasia is legal in India. Passive euthanasia is nothing but withdrawing of life support, withholding of life support. Passive euthanasia is not a correct word actually. Internationally, it is not a very acceptable word. But in India, the court came out with this. We are working with the court to modify this terminology because it's very confusing sometimes. Passive euthanasia means sometimes we think it's euthanasia, which is not. It's withholding or withdrawing life support. Stopping treatment when the burden outweighs the benefit. Not giving blood transfusions, not euthanasia. Yeah? Using morphine and other drugs to relieve pain. When you relieve the suffering by these kind of medications, it's not euthanasia because your intention is to provide comfort, relieve suffering. So intention is looked at. That is the fact that in your palliative care training, I'm sure all of you had some idea about medical ethics even during MBBS days when you studied your medicine. But we discuss more about medical ethics in our practice, in palliative care practice, because we are going to face this again and again in our end-of-life care situation. I'll give you examples. Informed consent. Most of end-of-life care situation, they are drowsy, they are not in that frame of mind to take decision. So when you want to do a procedure in such patients, how can you get an informed consent? Isn't it an ethical dilemma? Suppose this Sanjay, this boy, he is not fully conscious now, drowsy, and we need to do pleural tapping for him. Suppose lungs are filled up with water, I need to take out fluid. Can I get an informed consent from him? It's difficult. Sharing of information, the same thing which you discussed. Family says don't tell the patient, and you know that this patient is dying, and you need to discuss with the patient about his wishes, how he wants his end-of-life care to be. But the family is saying don't tell. It is a big conflict. And often we face this very common in our practice. Hydration and nutrition. When somebody stops taking food and fluids, patient with advanced dementia. Have you seen patient with dementia? Yes. When they progressively become more and more decline and advanced dementia, they stop taking food because they can't swallow and they become very frail and the family feels very anxious. So, kuch to khana dena, how can you stop feeding? The fact is that the nature, that is how, as the body function declines, the need for body to have nutrition and hydration comes down. It's a nature's process. We should allow it to happen. We should not be subjecting them to feed because they will not be able to tolerate that. Even if you give by artificial means, they will not tolerate that. But still this pressure, because in our culture, giving food is something, it's a feeling of nurturing. And we think that is one way to show that we care. But sometimes that can produce more harm than doing good. Many patients, they choke to death because of that. And many dementia patients have seen family force feed something and they suddenly die. So, hydration and nutrition. Cardiopulmonary resuscitation. Advanced cancer patient, advanced age when they are dying, will you go for cardiopulmonary resuscitation? But many hospitals, when somebody is dying, they have this, they press code blue, and it's not, there's a routine. They do that. Is it justified? We know that it happens. Ventilation, putting the patient on ventilator. Withholding and withdrawal of life support. Clinical decision making. Resource allocation and the terminally ill. We discussed that already. Research. End of life care patients. Many times the research becomes more challenging than normal patients. One, the outcome is very difficult to assess, isn't it? And they're not fully conscious and they're not fully competent. How can you assess the response? Suppose somebody is in pain now. Sanjay, this boy, he's in a lot of pain. I want to assess the response to his pain. but he is unable to respond to my questions. What kind of research I can do in terminally ill patient? That comes with its own challenges. Yeah. So all these are situations which we face in end of life care. And we don't know. Sometimes we face this dilemma. One thing you have to remember: decisions in palliative care setting are often made in an environment of emotional distress. In palliative care, we often emotionally charged environment. Family is upset, patient is dying, we are also upset. So often there's a lot of emotional overplay of emotion in that situation. Doctors should be sensitive to the human vulnerability, dependency, and fragility of the patient who's critically ill. Patients are vulnerable. You give them any little hope, they cling on to that. And they're very vulnerable and they depend on you. They look upon you, doctor, aap batao kya karna hai? Because they're so scared and they're so vulnerable. So when you make decisions, you should be consciously aware of that they are depending on us. So we should, whatever little you tell them, you should tell them with sensitivity. If you say, yes, blood transfusion, they'll cling on to that. Yeah. And same like this to family member acting as proxy. I have one patient right now, and hopefully after this, sometime in the evening, I'm going to see that patient. It's a patient who's extremely wealthy, very super rich patient. They give almost like 2 to 3 lakhs every month as a donation to our society, every month. Such wealthy patient. He developed multiple myeloma, underwent treatment in one of the big hospitals here in the city, and her bone marrow is now completely failed. Multiple myeloma relapse, completely failed. Multiple myeloma also affects bone marrow, completely failed. So, because they were lots of money, so when you have more money, then you are in more trouble. So you go to the best of the hospitals, and they keep going to the top oncologists, and doctor, what to do. So top oncologists also not knowing how to deal with such patients. Most of them, they're not trained in these kind of situations, how to deal with these situations. They just know how to treat. So they just say, okay, you take platelet transfusion because they're worried that she may bleed to death. So she's caught on to that. Now she thinks this is lifeline. If I take platelet transfusion, then only I'll live. So every week she's going to the hospital and shifting this. She lives somewhere this side, and the hospital is somewhere near Banjara Hills. So she has to travel in a week once or twice minimum to that hospital. It's very difficult. She can't even get up from the bed. Her performance status is very poor. Can't get up from the bed. And this lady, she's taken almost weekly, once or twice in a vehicle to this hospital there, and she receives blood transfusion. And then she goes back. It's not stopping. And we don't know how to tell them because they are clinging on to that. That doctor told me. So today my intention is that I'll go and meet that doctor myself and kind of have a kind of open discussion about the futility of whole thing. And many times doctor leaves instruction. They don't even see the patient afterwards. Weekly transfusion, they'll just write. And they keep on taking weekly transfusion without thinking much about it. But I feel that she may not live for another 2 or 3 weeks. What would you think that she should be doing with the 2-3 weeks she has?
And this patient is having a hope of living. She is thinking that she will be able to live a better for at least 1 week with the blood transfusion that she is doing.
Very good.
Suppose I'm going to give her a feeling that, it's futility, staying this, something of this, I'm going to expose to her and say that I'm going to give you this. I'm going to talk that right.
Absolutely, I want to respond to that. Before that, when I asked her what is that she wants, little bit about her information, she actually doesn't live here just for this treatment, this madness of treatment. She's come here to the city. She lives in Madanpalli, another very far away district. And she has stray dogs. She runs a home for stray dogs. She has many dogs there. And she told me, the moment I feel better, I want to go back to Madanpalli and I want to be among my dogs. That's my life, she said. Now, here we have 2 to 3 weeks time left, suppose, for this patient. Ideally, let's talk about ideal situation. What should be the ideal situation? She should be given the choice to go back to Madanpalli, be with her dogs and family, and without suffering, she should be living there. till the end of life. That's the ideal situation. Now here you have this dilemma about taking away this hope. We say, yes, we all need hope to live. When we live on some hope. If there's no hope, then we'll stop living, isn't it? So what we talk about is giving the realistic hope. We say that once you're taking away this hope by telling her the futility of treatment, taking away that hope, but you also instill another hope, the hope that the little time you have, I want to give you this chance to you to go back to Madanpalli, spend the time with your dogs and family. Would you like that kind of life for you than living in this strange city, in this strange rented house? She lives in rented house. There's no one around, just except for one sister who's there. And sister is also very high strung. She's kind of seeing her sister dying. She's unable to handle, and very high strung sister who's there. So when you talk about hope, think about giving realistic hope. So the hope, you may take away one hope, but you give another hope that even though I'm telling you this is not going to be helpful, but I'll make sure that you're not suffering. The time you have, you should live without suffering, and you should be with your family, with your friends and your dogs. Do you think that's the kind of thing you want? Most patients, they will be very grateful to you for telling you that. You'll be surprised.
We have with that patient, explained something. That patient is quite aware of her signals.
Oh, you know that patient? Yes. Yeah.
I met her.
Okay, tell us more. She has seen the patient. Tell us more about it.
Yeah, that patient is very much aware of her signals, even the metastasis, everything what is there. And still, as you said, she is hoping to go back to.
Yeah. The another problem with that patient, the problem I found, when you were discussing these things, talking to her yesterday, who was there with her?
Her son.
Okay. For change, now her son is there.
Yeah.
Till yesterday, she had a very overpowering sister, decision-making sister, who was making decisions for her all the time. Very overpowering. And we never got a window to talk to the patient directly. So even though she's projecting that brave friend, I don't know like what's inside her mind, because sisters all the time, no, you should be positive, you should be strong. We'll take care of you. In this whole process, she's trying to be strong, and I could see that somewhere when I asked some questions, my face was like kind of worried, little concerned. So I never got that window to talk to her directly because her sister was always there. I will take care of her. Don't talk to her like that. Now because the son is there, maybe we'll have that window.
He gave a lot of space for her. He gave also a lot of space for her to speak. She expressed all that what she went through, what she's having.
She had a difficult life. All her life, she had a very difficult time. And this is the only time I think it seems, I didn't get the chance to speak to her. This is what I heard. She said, now is the time I got, husband was a very difficult person. Very difficult life she had. He died a couple of years back. And she said, now this is the last 2 years, I'm living my life the way I want. And her life is wanting to be with these dogs and doing creative things, a lot of things. So she wants to live that life. And right now she's not doing that. All she's doing is going to the hospital, blood transfusion, come to this building, concrete building where she's in a rented house. What I'm saying is, we should at least create that opportunity. Then the choice is with the patient and the family. But the point is, what we do most of the time in a medical profession, we never give that choice. We don't provide that opportunity for these kind of discussions, that choice. Sorry, somebody had a comment here.
Yeah. Some patients just want to be alive for the sake of being alive. They are not worried about the quality of their life. They just want to.
That is their choice. But have you given?
Now,
yes.
Like if you explain to them that this is their outcome, they may are they in a disposition to receive that explanation. Or
So,
they will say, if this doctor is trying to they will go to another one.
So the question is,
like that.
yeah. So among 100 patients, you may see one patient who will respond badly to these kind of responses. And then you make a blanket decision that all patients should not be given that kind of choice. My thing is, the contention is that if the patient wants to know, you have the right to give that info. You have the duty to give that information to the patient if the patient wants to know. The patient does not want to know, you should not impose information. But if the patient wants to know, you have the duty to give enough information. Number two, you must create that opportunity for the patient to ask that information. That opportunity is never created.
How is it created, for example?
Okay.
In this particular case, the treating doctor, whoever, you say, he just write weekly. Now, a third party going and telling, oh, I was happy to hear that you said that you will go to the doctor concerned, and because if the third party tells her, she may not be able to accept it. So, don't you, I feel it is also a failure on the side of the treating physician knowingly or unknowingly, not taking the pain to see her, meet her, explain to her.
That happens most of the time. When you ask about the opportunity, the treating doctor never created that opportunity to find out what is that patient wants. He just gave his clinical decision that bone marrow failure, platelet transfusion. If you just look at, not looking at patient's declining condition, what is the treatment for bone marrow failure? Platelet transfusion. That is a very clinical decision without looking at patient's performance status or patient's declining condition. And most doctors, we all, when I say most doctors, I am also part of it, I make that clinical decision based on lab reports, the bone marrow report, and I make a decision. If you just look at that patient, maybe you will not make that decision. And this doctor, I hear, is one of the most busy, I know him very well. That's the reason I'm thinking that I may go to him. He's one of the most busy doctor. For 30 days, people wait for his appointment. If such a busy doctor, do you think he's really seen this patient in a recent times to assess his physical condition? Every clinical decision should be based on patient's clinical condition, isn't it? And we get those, sorry, we'll come back to that. I get a lot of these phone calls, patients, brother living in US, one doctor living in US, and doctor in the US said you have to go for surgery. And you get this phone call, they say, okay, doctor, will you speak to that doctor? He's calling on the phone. It's very sometimes distressing, very irritating sometimes when a doctor is sitting there and he looks at radiological diagnosis and he gives a decision that this patient needs to go to surgery. Often that leads to a lot of problems.
And
Yeah.
my question is, you also said about the socio-economic life. So is it quite a bit, it is a social symbol about the most, a doctor who is so busy and then the doctors are also taking advantage of that social symbol.
This is the norm is that, yeah, why doctors, yes, why people are losing faith on doctors is because they think the doctors are always looking at chance to extract money. And one example is, classic example is here, that the rich patients coming to doctors, so how to deal with, give him blood transfusion. That's the easier way out. Instead of looking at what is her wishes, what is her end of life care suffering, who's bothered with that? Here you're getting easy money, each hospitalization this much money. So his administration is very happy with this doctor. Yeah. And for the family, status symbol is there for them to go to one of the best doctors. If you notice, recently 2 celebrities had cancer. One is Sonali Bindre, I don't know whether you keep track of those things. Sonali Bindre is famous actress, and there was one, Irfan Khan, one more famous actor. The moment they were diagnosed to have cancer, they flew to US. Sonali Bindre is having high-grade metastatic cancer. She's not going to live, whether she's in US or MNJ, outcome is going to be the same. Yeah, even for Irfan Khan, it's a glioblastoma multiforme. It's a bad cancer. But this is the status symbol, and also the thing I should, because I have money, I must go to best doctor. That concept of going to best doctor. That's what they do. But even for them, if you give the choice, they will think about it. I have treated a couple of very famous celebrities in this city for palliative care because they were intelligent enough to Google what is there now next for my father, and they saw palliative care and they looked for palliative care doctor in the city, and I got this phone call. I went, and when we discussed, they said, please, we just want this palliative care. We'll keep him in the home. My father lived a life of a hero. He should die a life of a hero. He should not be in some ventilator alone with no dignity, all tubes going down his all over the body. I don't want that to happen to my father. The family took that decision. Very famous, one of the leading hero here in the city. I provided palliative care, but that opportunity came to them. How did Jayalalitha die? Miserable death. I don't know how many of you know Sai Baba, one of such a high profile person. His life was miserable. He had a cancer death. His life was miserable. He didn't receive any palliative care because this whole thing about managing his wealth and his trust and everything in the process, he never got any palliative care. So it was hushed, hushed. All our VIPs, they die miserable death in India. Why in India? There was a big hue and cry made in South Africa after Nelson Mandela died. Nelson Mandela died a miserable death. And because South Africa is one place where there's a good palliative care happening, and there was huge newspaper articles written about why was Nelson Mandela subject to such horrible death. Just because he's high profile, because political, when somebody's big politician they die, they don't reveal that he's dying till they stabilize the political situation in the country. Yeah, in that process, the person suffers, isn't it? So that's if we can start discussing, this never ending. But
this question, yesterday when we met, today Dr. Nasima had spent really enough time with me here. I really appreciated her the way she approached her. But this patient is quite knowledgeable about her disease. She knew her bone marrow is not working, and her platelets are when it is less than 20,000. And so I need blood transfusion again. And
knowingly,
so,
that's
knowingly, that is what I said. That ray of hope that is in her. If you are going to tell her that.
No, I'm not going to tell anything more. She already knows. She already knows that my disease, bone marrow is completely failed. If I don't take this platelet, I'll die. But I'm suffering because of this platelet transfusion. She's making an informed choice. This is what we call the informed choice. She's making a choice when she's fully aware of what is happening to her. Then it is her choice.
Yeah.
But most patients, they don't make informed choice. We make the decisions for them, which is not right. So when you're coming back to your question about how do you create that black atmosphere, what I mean to say is create that, try to help them to make an informed choice about their life. When I say informed choice, information is very important, that they get the right information for them to make a decision. But we don't give that choice. When the patient comes sick, quickly, there's a code blue, we do recessive. Do we discuss with the patient? No, there's no discussion. Code blue, ventilator mein dal diya, khatam, over everything. Then there's no informed choice there. So can we think about, take a step back and look at a different way of doing things like than how we are normally doing in our practice. Like I said, ethical dilemma, there is often no right or wrong answer. But we are not very sure, use this principle, try to balance all the components. And finally, if you're really, really not sure, I really go by her response, what you said in the beginning. What if it were me? That's something you can, based on that, you can tell the patient. And like I said, whatever decisions you think is appropriate for the patient, the important part is informed choice and shared decision making. You give the choice, and after that, have a conversation. The patient says, no, I still want to try that platelet. Okay, if that's what you feel, we'll take care of, you carry on with your platelet, but we'll take care of your pain. Just have some kind of shared decision making, and maybe talk about antibiotics, because she's also on antibiotic. Every week she's getting antibiotics because she's developing pneumonia, which is again, it's not helpful again. Every time she needs cannulation. So list out the problems and have a kind of a shared decision making as the best way we can help you. Ultimately, it's her choice, informed choice. I stop here. Is there any more questions? We'll take it. Any questions?
When two doctors differ in opinion,
now we know that clearly that platelet transfusion is not going to happen. The other doctor in the city wants to continue his business or whatever. Then the patient will be confused.
Absolutely. They often we face this dilemma when there are two conflicting opinion about one care, one particular problem. So what you should be doing is what you take you give information to the patient as to what you think is right. Understanding patient's medical condition and understanding all the components of medical issues like autonomy, what patient wants, do no harm, do good, and justice. Based on all that, you give the information which you think is appropriate for that patient in terms of your goal of care. And in spite of that, if the patient decides to still, and then the patient decides, if the patient decides to go for other doctor treatment, you should always be ready to hand over that responsibility. It's not about that you have to hold on to that patient. And you can always leave the door open for that patient. Okay, at any point of time, if you feel that you need to talk to me, you need more help, I'm always there for you. So leave that door open for it. Like it's very easy for us to get angry because why is she not responding, listening to me? Why is she going back to Senthil or whichever or Sudha? We can say, but end of the day, we want to help the patient, isn't it? So instead of getting into that that feeling angry about it, understand patient's perspective. That if she feels that is her lifeline, maybe okay, then you say that I can't do this, but you carry on with the treatment which suggested by other doctor. But any point of time, if you need help, I am there for you.
Two doctors' opinions differ, but it can also be the opinions differ not on the disease process or anything, everything is same. Maybe also the response.
Absolutely.
So I personally think there is a lot of that is going on in our practices.
Absolutely. A lot of unethical practice, vested interest. In that, it's your responsibility to give information. Again, I will still come to talk about giving information as a doctor. And I'll say, if I were in your position, I would be doing this. So please think about it and take a decision.
Sometimes among the doctors also, not within the institution, when they go to somewhere else, the reason that common goal of the patient is our goal is, I think that's
missing.
That's missing.
Absolutely.
And even the doctors are also not willing to really consult one another or to have that type of an open discussion to stay this way. Then doctor is also betrayed by another to the patient. And so I think there is a lot of ethical problems happening not between patient and doctor.
Absolutely, I totally agree with you. Among medical health profession itself, because the health has become an industry now. So in that, always there's a conflict of interest, and we are caught in between. And so, but still, we have a duty to, as a person, as an individual, we can always work towards patients' well-being and give the information, and then it's patient's choice. Yeah.
The patient says, suppose his patient, he says, the Lord reveals to my partner or wife. So in that case,
I know this. I know you face this dilemma very often, that HIV positive patients saying, "Do not reveal the information." Actually, if legally, I think you're bound by that. Legally you're bound by that. But still, we should go out of the way to persuade. We should try. It's very difficult. We should try because it's going to harm another party. Then we should go out of the way to break that pollution and work towards that. But legally, the patient says no, we can't do anything about it. But we can still try and understand why the patient is saying no and work around that problem. Very often we don't try to understand patient's perspective, why the patient is saying no. So if you can explore a little more, sometimes we are able to break. It's very rare. So we cannot generalize. I'm saying there's like 100 patients we should try. Maybe one 95% you will be able to break. 5% sometimes we fail, and then you say that then if you cannot deal with that situation, you can always transfer responsibility to another person, because morally you will not be able to help that family. Should be then you should not we should decline. Normally we say, suppose in spite of my repeated persuasion, patient still wants to go for TPN. We face this situation, TPN for end of life care situation, which is not right. It's a futile treatment. But they say, no, doctor, you have to give me TPN. I say, for me, I feel that is not the right way to help you. But if you really insist on TPN, there's another doctor who may be willing to give. Please go to that doctor. There's no harm in doing that. Don't feel bad about losing that one patient, but always leave the door open. Don't think that I'm angry with you. Any point of time you want to come back, I'll be there to help you. Same thing happens with alternative treatment. A lot of our patients, they leave the main treatment and they go to alternative treatment. The same dialogue we have, conversation about that.
I managed successfully one patient who did not want to reveal that she was having HIV positive to his partner. And he wanted to know that whether partner has got HIV positive or not, because he knew he was HIV positive. And he was hiding and she was getting continuously sick. So this man wanted to hide from her completely. At the same time, he had the fear that she's going to get it. Now I asked him, suppose something happens to you, and that life is going to be miserable, and you do not know, you are not going to take this. At this moment, it's not better that we give that news. I made him aware of his responsibility to sharing that news because he is sharing this. I hope you must have done it, because I said, since you are telling me not to tell about this, I am bound. I cannot explain that truth to you. It is your duty to take care of her and then share this. I hope that he has done it.
I'm sure at least you must be thinking about it. And thank you very much for sharing that. I know all of you have this wealth of your own experience of dealing with very difficult patients. But this only message I want to give here is that take a different viewpoint from what I know. I also practice medicine, anesthesia. My background is anesthesia, and like we just follow without thinking. A lot of things we do without much thinking because we learn from our seniors and we keep doing that. There's another viewpoint. Can we think a little differently, and can we help our patients in more better with this approach? This is way of trying it out, and you'll be surprised that it's not so difficult as we think. If we can take this approach. Yes, we do get some difficult patients, but majority you are able to help them. Thank you. I think we stop here. It's almost 1 hour. We'll skip the case presentation. We can just tell them because it's almost 1 hour. Yeah. Thank you very much. It was nice talking to all of you. Thank you.
Hello, madam.
Hello.
Yeah.
Shall we skip case presentation? Sorry about that.
Okay. Can I see them? Hi. Then there will be a session on Friday on adjuvants. Who will present a patient story? Next echo session is on Friday, next Friday, coming Friday. So it's the session on adjuvants. So any one of you can present the patient story. Say any pain patients.
Any pain patient?
They are reaching only on that day.
So they have a concern that they're all traveling back and reaching on that day.
Okay. So, is it difficult?
I think Friday will be difficult.
Yeah, Saturday is better.
Saturday will be better, they're saying, because they're just reaching on that day, traveling long distance. So I have to
maybe it's not possible that session is will be taking one of the outside faculty. So because of her availability, we can't postpone the date. Anyway, I will talk to the concerned person and let you know.
Okay, they're saying thank you.
Okay.
Can we leave the meeting?
Yes, madam.
Thank you. Thank you very much.
Thank you so much. Thank you.
Bye-bye.
Bye.
Vishnu Narayana Namudi. Oh, then selfie എടുക്കാനോ?
The Netco ഉണ്ടായിരുന്നു. Chai Foundation Netco ഉണ്ടായിരുന്നു.
Oh,
Gayathri